Good evening, my name is Dr. David Doman, and welcome to another edition of Housecall. Colon cancer, a major cause of cancer death in the USA. What can you do to prevent it for yourself and your loved ones? My guest this evening is Dr. Sindu Stephen, a gastroenterologist practicing right here in Montgomery County. Dr. Stephen, welcome to Housecall.
Thank you.
So briefly, tell our viewers about your professional background.
So I actually did my internal medicine training at George Washington University and my GI residency, gastroenterology fellowship at George Washington University. And then now I practice at Montgomery Gastroenterology with you.
Yeah, in Silver Spring.
In Silver Spring.
Very good. And explain to our viewers, what exactly is a gastroenterologist?
So a gastroenterologist is a physician who specializes in the colon and kind of the gastrointestinal tract. We do training in internal medicine for 3 years after medical school, and then 3 years after that we do specialized training to learn how to do more invasive procedures for endoscopy and colonoscopy to examine that tract where we digest food.
Sure. So let's go on then to focus on the topic at hand, colon cancer. How bad is the situation nationally?
Well, at this point, colon cancer is the second most common cause of cancer deaths in America. And it's also, you know, they have said about 50,000 people annually die from colon cancer. And it's mentioned that even though it's very, the screening is very available, we're not, only 1 in 3 Medicare beneficiaries actually get a colonoscopy. So a lot of people are not getting what they should to prevent and detect colon cancer early.
Why do you think that is, that many patients that are eligible to be covered are not getting necessary testing?
I think there's always a fear about an invasive procedure, and also kind of just the accessibility of learning about what colonoscopy is, how important it is, and that it can actually prevent colon cancer and not just detect it.
Well, we'll set the record straight tonight then. So what then are some of the risk factors for developing colon cancer?
Well, you know, they're still not sure about all the risk factors. There may be something to do with our poor nutrition, but definitely age. Age is one of the big risk factors. As we get older, there is an increased risk of colon cancer. So we recommend that people start screening for colon cancer at age 50. But for African Americans, we recommend 45.
Why is that?
So in 2009, actually, the American College of Gastroenterology published guidelines we should start at 45 because there were studies that came out showing African Americans actually have a higher rate of colon cancer, and they also have a decreased survival rate if they than other ethnic groups.
There's a higher risk in the community. Now, there have been, as you know, recent reports of colon cancer appearing in younger and younger patients.
Yeah.
What are your thoughts about that?
So it's interesting because even though colon cancer rates are decreasing with increased screening, the risk might be increasing, maybe because of obesity, poor nutrition, and inactivity. Mm-hmm. They actually stated in that study that individuals born in 1990s might have quadruple the risk of rectal cancer than someone born in 1950 and double the risk of colon cancer.
So whereas now the standard of care is to begin screening everyone at age 50, or if you're African American, age 45 and older, it certainly is conceivable that we may change those guidelines in the future.
Right. It may get, we may start screening younger, but as of now, we still start at 50, and 50 for the general population and 45 for African Americans.
Let's then discuss and explain to our viewers what is the rationale for colonoscopy? How does it potentially prevent and cure colon cancer?
So when we perform a colonoscopy, we actually use a long tube, which is a colonoscope, which has a light and a camera at the end. Insert it through the rectum, which is the end of the colon. The colon is actually a 5-foot tube, and it absorbs water and minerals from food and eliminates solid waste. So as we go through the colon with this tube, we can project the images on TV and look for cancerous growths. And if we find it, some of them, if they're precancerous, we can remove them.
And what are the different types of growths that you're referring to?
So these growths, they start at the lining of the colon, and as they get bigger, they can become like these mushroom growths. And we can do different procedures, like there's a biopsy forceps where we can just kind of take a bite of it and remove it. Or we do something else where we kind of put a lasso around it and burn it off. And all of this is not a surgical procedure, it's an in and out procedure. And by doing that, when we remove these growths, we send them off to the lab and we can find out if they are precancerous or they're completely benign. And by knowing this, we can tell patients how often we need to do a colonoscopy, or can they just do a colonoscopy every 10 years, which is what's recommended in average risk individuals.
And these growths are also known as polyps.
As polyps, yes.
So I think what will be an eye-opener for our viewers is when they hear the following statistics. If you take 100 men that have no symptoms and you do these routine screening colonoscopies, statistically speaking, how many of them will have polyps when you do a procedure?
I mean, on average for men and women, they say we should be finding somewhere between 20 and 30%. But I could say personally, when I've looked at my colonoscopies for the past couple of years, it's been roughly around 40% for men and 30% for women.
So it's really quite high.
It's quite high, yeah.
So let's discuss then the logistics of a colonoscopy, because as you said earlier, many patients who are eligible to get colonoscopies don't get it because of fear of the unknown.
Right.
So let's talk the viewer through what's involved. First of all, is there a bowel cleansing required?
Yes, and I think that is what everyone kind of dreads. That's the worst part of the procedure. The procedure itself, people usually don't mind it at all and they don't even remember it. But the cleansing part is hard. So the day before the procedure, we ask patients to have a clear liquid diet, so no solid food at all. And then in the evening, they take half of the laxative that we ask them to take, and 6 hours before they take the second dose. Now, this laxative is a powerful laxative, so you need to be close to a bathroom, and it should clean you out. Eventually, your stool will look like clear yellow fluid, so it will clean you out.
Patient then comes in to have the procedure. After doing some paperwork, what do they experience when they have a colonoscopy?
So usually they'll come in and they will be seen by the nurse and the anesthesia provider. After they're evaluated, they're usually, after we speak to them, we put them, they're kind of put to sleep a little bit. It's not general anesthesia, it's like mild sedation, but they are not aware of what's going on. And then we do the procedure, and after the procedure's done, they wake up and they usually feel fine. They may have a little gas or cramping because we do have to put in air as we're inserting this tube so we can see the colon clearly to look for these polyps and growths. But otherwise, they feel fine. And they go home. They're probably hungry and tired, but that's it.
And how long does the procedure typically take?
Usually anywhere from 15 to 30 minutes, but it could take longer if they have polyps. Otherwise, 15 to 30 minutes. But they have to anticipate being at the center for a little bit longer, maybe 2 hours.
Okay. And when they're done, do they need somebody to drive them home?
They do, because they are given sedation. So even though they feel awake, we don't want them driving. So someone does have to accompany them to the procedure.
Tell me then about some of the concerns in terms of complications of colonoscopy? What are the national statistics on that?
So colonoscopy is generally pretty safe, and it is the preferred test for cancer detection from all the gastroenterology guidelines and American College of Gastroenterology. But there are some small complications that can occur, such as bleeding, infection, perforation. Perforation is a tear in the colon. It's not common, but can happen anywhere from 1 to 3,000 or 1 in 3,000 or 1 in 5,000. If it happens, requires surgery, but is not that common. Even though that is a risk, I would say the benefits of colonoscopy outweigh the risks. If there's a patient where we feel the risks outweigh the benefit, then we can talk about other tests that can be done.
Okay. And what are some of the potential other tests available to screen for colon cancer?
So colonoscopy is probably the only cancer detection test. There are some the cancer prevention tests. There are some other cancer detection tests like fecal immunochemical testing, which is stool testing. And patients can do this at a lab where we test the stool for microscopic blood. Mm-hmm. Even though this is a good test, it has to be done annually, and it detects cancer about 70% of the time and large polyps 30% of the time. And it can be falsely positive about 5%.
Where there's nothing there.
There's nothing there, but it's just positive. And there's a newer test out called Cologuard, or fecal DNA, where it also tests the stool, but it looks for microscopic blood plus fecal DNA that's shed from large polyps and tumors. That can pick up cancer in 92% of patients and large polyps in 42%, but it has a higher false positive rate of 12%.
Okay. Is it your sense that the stool for blood or the stool for DNA are meant to be complementary to colonoscopy or replace it?
Yes. I personally, if I give someone a 10-year interval, because that's what we do. If someone has a normal colonoscopy, we would say, come back in 10 years. I recommend that they test their stool for blood from year 5 to 10. But different people do different practices. I just do that just to be safe, just in case that even though colonoscopy detects most polyps, you can still miss some smaller polyps.
So if any of these stool studies during the interim are abnormal, then what will you do?
Then we would repeat a colonoscopy.
Okay.
Yeah.
And then is colonoscopy covered by insurance?
It is covered by insurance. So colonoscopy is covered. Of course, every insurance is different nowadays. So, but screening colonoscopy, which is a patient with no symptoms just doing it because they're 50, should be covered by all insurances.
Very good. And what about Cologuard and stool for blood? Is that covered by insurance?
It should be. I know the fecal occult blood or the fecal immunochemical testing that I order, it is covered by most insurances. And the Cologuard is covered by Medicare and most insurances, but that's done every 3 years, not every year. And that may not be approved by all, so that I'm not sure.
Okay. Well, we're going to pause briefly for a public service announcement. When we return, more with gastroenterologist Dr. Sindu Stephen. We'll be right back.
That's low, that's low.
The average text takes your eyes off the road for nearly 5 seconds. Stop the texts. Stop the wrecks. Visit us at stoptextstoprex.org.
We're back. My guest this evening is Dr. Sindu Stephen, gastroenterologist here in Montgomery County, and our topic is colon cancer screening. Dr. Stephen, when we paused for the break, we were discussing colon cancer screening, and many of our viewers may be thinking, well, gee, why bother to get screened for colon cancer if I feel well? Why bother? So what are your thoughts about that?
Well, most of the time, colon cancer is really asymptomatic. People don't have any symptoms at all. The polyps that grow, they start small and you have absolutely no symptoms. It's only when it grows larger and it becomes colon cancer and it's kind of growing into the colon and it's quite large that you may have symptoms of bleeding or maybe you have a change in the bowel habits, like a sudden onset of constipation, or maybe a thinner caliber of stool. You might even have weight loss or abdominal pain, but again, these are very late findings. It's not early findings for colon cancer. Usually early, you're completely asymptomatic. You feel normal.
Is there an advantage then to the patient in terms of survival if you pick up a colon cancer early when they have no symptoms,
Yeah.
as opposed to diagnosing it when they do have bleeding or a blockage of the bowel?
So if you detect colon cancer early, the 5-year survival rate is over 90%. But only 40% of colon cancers are actually detected early. So it's very important, if we screen as we're supposed to with guidelines, we may actually be able to decrease the colon cancer death rate. I think American Cancer Society said that we might be able to cut it in half. So.
And what exactly has been some of the preliminary data nationally about the results of colonoscopy? Has there been a benefit in terms of reducing colon cancer?
They say that we can detect about 75 to 90% of polyps that are 10 millimeters or larger, and actually around 90%, and around 70% which are 5 millimeters or smaller. So there is a benefit to detecting. We know that these polyps will grow into cancer, so there's a benefit by doing colonoscopy to prevent colon cancer.
You mentioned earlier that we should begin screening patients at age 50, unless they're African American. You begin performing the exam at 45. Let's say you do these exams. Which patients are told to come back in 5 years, and which patients are told to come back in 10 years?
So if you're an average risk individual, I guess first I'll just talk about who's average risk and high risk. Average risk is just someone who is just 50 years old with no family history. So family history would mean a first-degree relative who has colon cancer or colon polyps that's 60 years or younger.
Define for our viewers what you mean by first degree.
First degree means like a mother, father, or sibling.
Okay.
Second degree relatives, which would be like grandparents or cousins. If you have two of those, two people who had colon cancer or colon polyps before age 60, that would also be considered family history. So if you have family history, you actually start screening 10 years before they were diagnosed with cancer, or 40, whichever is earlier. And you screen, and you would do a colonoscopy every 5 years. If you have certain chronic digestive diseases like ulcerative colitis or Crohn's, you may actually, after 8 years of disease, have to have a colonoscopy every year or 2 years. And then people who have polyps have to have a colonoscopy every 3 to 5 years. It depends. Sometimes if we find a really large polyp or a flat, kind of aggressive polyp, we may suggest a year or 1 year, 3 years, or 5 years, depending. But usually, if you don't have polyps, you would get the 10-year interval.
Let's then discuss the extreme that you do a colonoscopy and you find a polyp that has cancer in it. Where do you take the patient from that point forward?
So, actually, if a polyp has cancer in it, if we can remove the whole polyp, then that's it. We've removed the cancer. If, of course, it's larger than that or it's spread a little bit deeper, then we actually, we have to stage the patient to see if it's spread to any other organs. And if it has, they may need surgery or chemotherapy. It just depends on how advanced the cancer is. But sometimes, if it's just localized within a polyp, we may be able to remove it without referring them for surgery or chemotherapy.
And then if they do need surgery, many of our viewers are concerned that that means an automatic bag or colostomy. Clarify what you mean by surgery.
Well, so if it's localized, they can actually just remove a portion of the colon. So they would remove a portion of the colon and some of the lymph nodes that are attached to that colon to make sure it has not spread. And it does not mean a total colectomy and a bag. A lot of them are just removed segments, just segments of the colon and that are removed that have the cancer in it.
And then they hook you up good as new.
Right, and then you just have normal bowel movements and you feel fine after the surgery. And a lot of these surgeries are actually done laparoscopically, so you don't even have a big scar from it.
If somebody has colon cancer, does it mean automatic chemotherapy?
Not all the time. It really just, it depends if it's spread to the lymph nodes or not. If it's, it depends on the stage of the cancer. If it's an earlier stage, a lot of times surgery can be curative. And again, the survival rates, if it's early and not spread, over 90%. So,
what do you think is some of the things that can be done to encourage people to get colon cancer screening?
I think, you know, a lot of people have fear of the complications. So if they actually looked at, if, you know, when we go over the statistics and we see how small the complication rates are, and by doing these colonoscopies earlier, you can actually prevent it, more people would do it. But it's more understanding the procedure or the options. If they don't want to do a colonoscopy, at least do some sort of colon cancer screening. But if they have any indication to do it, or, you know, it is the preferred test, they should do a colonoscopy.
What are your thoughts about the X-ray virtual colonoscopy?
I think it's a good alternative. Again, it's not cancer prevention, it would be cancer detection because it cannot remove polyps. So the one part about it that people, I think, forget is that you do have to clean out for the virtual. So if you clean out for the virtual and they find a polyp, you have to clean out again and do a real colonoscopy to remove the polyp. But it is a great option for someone who maybe can't undergo a colonoscopy due to anesthesia risk or another reason. But most people, if they can, I would recommend a real colonoscopy. There have been some studies that came out saying that virtual colonoscopies are not good at picking up flat lesions. Mm. So for that reason, I would recommend a regular colonoscopy.
As you know, many patients, and you mentioned this earlier in your remarks, are reluctant to have colonoscopy because of the bowel prep. They've heard bad things about it. Mm-hmm. Have bowel preps improved over the year?
So there are different options. There's many options. Some younger patients can take pills. I personally don't use the pills a lot. There are some different solutions. Before, people had to drink a gallon, and that has come down to half a gallon or 2 liters, which is half a gallon. But there are better tasting laxatives on the market now. So we do have more of a variety. I wouldn't say they're the most pleasant tasting, but we've come a long way. So it's better. And we can aid people if they really can't tolerate the liquid preps. We can give them the pills, and we do have different options.
Dr. Stephen, explain to our viewers what exactly are quality measures in terms of performing a colonoscopy to prevent colon cancer.
So these measures have become kind of a hot topic amongst the gastroenterologists. It's something that we are actually trying to be better at. These are questions you could ask a gastroenterologist when you go to see them, because a lot of people wonder, what should I ask my gastroenterologist? How do I know, you know, they're doing a good job, or what kind of quality do they look at? And these measures were put forth by our national societies to kind of give us a guideline. So certain examples are when we do a colonoscopy and we get to the end of a colon and we're coming out of the colon, that's when we're looking for these precancerous growths or polyps. If we do it too fast, then we may miss things. So they want to make sure that we have a withdrawal time of 8 minutes or 6 to 8 minutes, so that way they know that we are actually able to examine the entire colon. They also look at what we call our adenoma detection rate, which means that every time we do a colonoscopy, if we find a precancerous polyp, which is otherwise known as an adenoma, how often do we find it? So if we're doing 100 colonoscopies and we're not finding adenomas at all, then maybe we're not looking hard enough. Maybe we need to clean the patients out more. We have to self-evaluate and know our rate. And so to know, they have a standard rate that we should be reaching. If when patients come, if they ask the doctor the adenoma detection rate, they can tell them what their rate is. They should know. Also, kind of what is their complication rate? So how often do they have complications? And is that, according to kind of the national guidelines, is that normal or not normal? How often do they reach the end? Sometimes
By the end, you mean the cecum?
The end of the colon, yep, right. The cecum. Very occasionally, sometimes we don't reach the end. So we have to, that's another thing that we have to look at. So these are some of the things that you can look at. On our practice, we've actually published it online as a tab under quality so people can look at the standards at other hospitals like Brigham and other hospitals in Massachusetts to kind of compare and see how we fare according to them.
What are some of the points you would make to convince them that colonoscopy is a safe, important thing to do?
So I would say definitely that it is easily accessible. There are many gastroenterologists. You can definitely find someone to perform a colonoscopy. It's covered by insurance. If you don't have insurance, there's actually a county program called Montgomery County Cancer Crusade, and they will cover you. So you can definitely get a colonoscopy. It's safe, and it's, considering this is the second most common cancer in America, I think it's worth you making the effort.
If our viewers have any questions or want more information, how can they reach you?
Well, they could definitely call me at the office and make an appointment. My number is 301-942-3550, or they could go on our website, www.montgomerygastro.com, and either way, they could definitely reach me.
Dr. Stephen, thank you for joining us on Housecall.
All right, thank you.
My thanks to Dr. Sindu Stephen for joining us this evening. My thanks to the team here at the studio. And most important, thanks to you, the viewer, for making Housecall the success it has become. We're now on prime time, 5 nights a week. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com.